should go ahead and get started to make the best use of time. Thank you all for joining us. Good afternoon. I'm Mario Barnes, the Tony Rimby Dean of the University of Washington School of Law. In this special course, Law in the Time of COVID-19, was created to address the extraordinary circumstances unfolding in real time around us in the world, in our nation, and here in Seattle as the earliest place in the US to be hit by the growing coronavirus pandemic. The course aims to provide a survey of the legal issues that may play a role in managing the health emergency, whether these are political, constitutional, or legal principles involved in managing COVID-19, or the social and economic factors shaping what we are now seeing as the quite disparate impact of the virus. For the next 6 weeks, the course will draw upon the expertise of stellar University of Washington law faculty and external guest speakers to gain a deeper understanding of law's role in managing a public health crisis of this magnitude. We thank you for joining us this week and invite you to return in subsequent weeks as we touch upon constitutional issues, labor and employment law, the impact of COVID-19 on vulnerable communities, the operation of court system, and innovations in legal services. The moderators have created a link to the roster of speakers and many of the course materials. Rather than read it out here, I will ask them to either post it on the www.law.uw.edu website or to post it prior to the end of this session in the shared screen. Although we have many more people joining us right now, we have 51 enrolled students who are already immersed in the class through written reflections, discussion, and sharing news items, questions, and concerns with each other and their instructors. The course aims to give them space to reflect on the virus and law's role in addressing it. It also invites them to be of service to their community as part of their final project, and that too is driving the face of this very public-facing series. As one of the premier public universities in the world, it is fitting for the University of Washington to orient our work in our teaching and our scholarship for how we can serve our community and the world. What theories can we offer? What practices can we demystify? What actions can we take as we use our legal skills and knowledge in service to making the world better in a time of tremendous crisis? We know we will not be able to cover everything that is important about legal issues surrounding COVID-19, and there are already many. But we bring you these 6 weeks of conversation in the spirit of sharing what we know, learning from each other, and carrying forward the idea that we are stronger as a community when we are serving each other. Thank you for joining us in this endeavor. I now turn this course over to its instructors, Dean Schumacher and Dean Saeed. Thank you.
Thank you, Dean Barnes. I appreciate that and welcome. I'm delighted to see that we have over 100 participants today. I'm Scott Schumacher. I'm one of the associate deans here at the law school and one of the instructors for this course. Professor Saeed and I put the course together, but we are relying heavily on our colleagues that are experts in the field. And today, I'm delighted to have many of our health law faculty joining us. So, just to start off with some questions. So in this unfolding crisis of the current pandemic, it's often seemed to many onlookers, including me, that nobody is sure who has the authority to do what and under what terms, whether it's implementing travel restrictions, issuing lockdowns, using the Defense Production Act, or accessing the national stockpile. Why is there no clear decision-making chain of command? There's so much in the news about actions of mayors, governors, and the president making decisions impacting life, liberty, safety, and economics with seemingly little, if any, coordination among them. So what are the constitutional and legal underpinnings of this seeming chaos? For this question, I'd like to turn to Professor Kuszler, who has a JD and also a MD. She's the Charles Stone Professor of Law, and she directs our Health Law LLM and our MJ programs and teaches in the law school, the medical school, and the School of Public Health. So Professor Kuszler, why is there no clear decision-making chain of command, and what are the constitutional and legal underpinnings of this chaos?
Well, it's actually rooted in our history very deeply. As those of you who've taken constitutional law probably recall, our framers, when they set up our Constitution, set up the federal government to have very limited enumerated powers. Now, those limited enumerated powers are broad in nature, but they are limited, and everything else defaulted to the states. That said, there is a universe of what we call concurrent jurisdiction. And as luck would have it, that is precisely where public health falls. There are references in the Constitution to public health and welfare. And so the federal government does have the authority to act in this arena and to pass legislation. However, traditionally, states have been the prime movers in terms of public health law. This really dates back to our epidemiologic revolution when we first began to conquer infectious disease such as infected water with cholera, where these local issues were dealt with by the state government, and even more commonly, it was detailed down even further to the local government, the state, the city, or the county government or the township. Now, this, for example, is particularly marked in New York, where much of our public health law that we use today, the so-called sanitation movement, originated in New York City with the infected water sources. So New York City has traditionally had an extremely powerful local city public health board and authority. Of course, the state of New York also has broad public health powers and has passed many of the laws. The federal government has frequently defaulted to the state and local government, even though they too have the power to enact law. Now, of course, in the coronavirus situation, we see this in full flower, because we see a question of who should be the boss here. And we see the states, notably Washington State, New York State, several of the other states, taking a lead role in addressing this epidemic. And in some cases, our cities, Seattle and New York would be good examples, where there's a powerful city public health authority. And then there's a question of why isn't the national government more involved? They could be. The truth is they have the authority to do this. It appears clearly, however, that at a national level, the Trump administration has chosen to step back and default to the governors and indeed the local authorities. That partly speaks to the chaotic approach. Now, you see, however, how faulty that is when you think of things like the Defense Production Act and the national stores for ventilators and masks, etc., and how those have essentially been not used as well as they could be, because the federal administration is more interested in having the responsibility fall on the governors and the states and the cities, rather than taking the helm as they might have in another kind of national disaster. Katrina is a good example. So you can see we have aggressive governors. Their aggression has been heightened by the fact that they have huge populations at risk. Some cities, New York and Seattle, where you've had a strong public health authority. And then in some ways, the coordinating, overarching national power has not been fully exercised by our federal government.
Great, thank you. Thanks very much. And so turning to the global picture, what role does the coordination with international authorities play here, or should it play? Can the U.S. do this on its own? And for that, we're going to call on Allyn Taylor, who is an affiliate professor for us and has been teaching for 25 years, or has 25 years as a practitioner, teacher, and scholar in international law organizations, and has including serving as a legal advisor to the World Health Organization. Professor Taylor, thoughts on the global aspects of this?
First of all, thank you, Professor, for inviting me here today. First of all, I think we should address the need, and to my perspective, and I think to most, it's patently clear that we need global cooperation to address this pandemic. According to the CDC, the coronavirus spread from its roots in China to 209 countries in just a matter of months. And if we think about that in perspective, it took AIDS 25 years to do the same things. So this rapid spread of coronavirus has vividly illustrated the challenge of battling an infectious disease in a global-wide world. You know, and it's widely recognized that as a consequence of globalization, we're living in an era in which there's unprecedented evolution in and greater pressure for disease emergence globally. And this mandates more effective cooperation, because it's a truism of epidemiology that diseases just don't know borders. And in order to contain a disease anywhere, you must contain it everywhere. So unfortunately, COVID has shown us how woefully unprepared we are as a global community to address our shared vulnerability to emerging and re-emerging pathogens. And many have pointed out, often incongruously, that there just doesn't seem to be a plan out there or any global leadership. But there is actually a binding international legal framework, which is the International Health Regulations, which were adopted by the World Health Organization, the UN Specialized Agency in Health, 15 years ago. Today, there are 196 countries that are state parties to the IHR, which makes it one of the most widely subscribed to agreements in the international community. The basic idea behind the regulations is WHO would serve as a central coordinating body in global public health emergencies. Countries would undertake surveillance, notify WHO, and share information to help scientists control outbreaks. And WHO would lead global efforts, coordinating containment efforts and information sharing, declaring public health emergencies, and making necessary recommendations. However, what we're seeing is that states are not implementing many of their core commitments under the IHR in the context of this pandemic. And some of these challenges are longstanding, including surveillance, but specifically in the context of COVID-19, reporting and limitations on restrictions on persons on travel contained in the IHR. And WHO is not taking up the mantle of leadership, at least in these early days. Now, all of this is undermining, I believe, our efforts to protect national and global public health. And there's no single explanatory theory that can explain why this is happening. I think from a realist perspective, this is to be expected. That, when states are vulnerable, they act independently. But I think it also reflects the undermining of our international institutions and global cooperation in health that we've increasingly seen in the last couple of years with the rise of national populism in countries around the world, including the United States. Now, the other body of international law that's highly relevant to state responses to COVID-19 is international human rights law. There's Lou Hankin, one of the fathers of human rights law, and it was one of my professors. I see another professor smiling. He pointed out that the idea of rights admits and accepts limitation of rights. And indeed, international human rights law recognizes that in the context of national emergencies threatening the life of a nation, restrictions on rights can be justified, provided that they are strictly limited, that they're based on scientific evidence, or non-discriminatory, of limited duration, proportionate to the objective, and subject to independent review. And these core principles of international human rights law are actually reflected in the context of the international health regulations. And around the world, we're seeing that states are implementing classic public health measures, such as isolation, quarantine, contact tracing, stay-at-home orders, bans on gatherings, large gatherings, and curfews that are restricting civil liberties, but are consistent with human rights obligations. However, there's growing concern in the human rights community, and actually there's a new report by Human Rights Watch, for those of you who are interested, that recently initiated state action supposedly justified by COVID-19 is inconsistent with human rights obligations. And these actions have included limitations on freedom of expression, including intimidation and lawsuits against whistleblowers and reporters, restrictions on movement, including overly broad quarantine measures, and discrimination in access to health services based upon other things, race, age, or disability.
Thank you, Professors Kuszler and Taylor, for that fascinating introduction to the role of legal authority in managing the coronavirus. We turn now to some of the social and economic impacts of the virus. And along the way, I just want to thank our speakers for being so concise. We kind of read them the riot act and said, we're going to give you 4 to 5 minutes and we're going to cut you off so that we make sure we get to everybody and we leave some time for questions. So to the public and to our students, if you have questions, feel free to put them in the chat box and we'll moderate that, and hopefully we'll have some time at the end to come to that. Our next speaker is Sallie Sanford, an associate professor with the School of Law and the School of Law and the School of Public Health. Her recent scholarship focuses on the Affordable Care Act implementation and the future of health reform. I feel incredibly lucky to have her as a colleague because she is truly one of the nation's foremost authorities on quote-unquote Obamacare. Sallie, tell us, as so many people are losing their jobs and we're seeing costs associated with managing the healthcare and all sorts of other economic costs associated with the coronavirus, what will the effect on insurance be of this pandemic? What does the landscape look like?
You're right, it is worrying. And as of today, there were 16 million people that filed for unemployment benefits. And there certainly are many more who are unable to get in the queue to even file those. And so what we're seeing is what's a health crisis and an economic crisis is rapidly also becoming a health coverage, a health insurance crisis. So I thought I would just mention briefly 4 aspects of addressing this before turning to what might happen in the future. And so the first aspect I wanted to mention is the marketplaces. These are often known as Obamacare or the Obamacare marketplaces, and that's where people can go to purchase an individual or a family plan. And if they're of low to moderate or moderate income, get pretty generous subsidies. So our state runs its own marketplace, and our state has decided to open up a brand new open enrollment time. So anybody can sign up right now. Go to WashingtonHealthPlanFinder.org and you can sign up. Now it's important to note that somebody who lost their insurance because they lost their job is entitled by law to their own special enrollment time, narrow window of time to sign up. However, by making it a generic open enrollment, it obviates the need for a lot of the paperwork to prove what kind of insurance you had. And it also allows those who declined to purchase a plan last fall or couldn't afford it or bought one of these, they're technically called short-term limited duration plans, also known as junk plans or skimpy plans that have been promoted. Those who bought those plans that aren't much use if you have a difficult hospitalization, to go ahead and buy a new one. So our state and 11 others have opened up the marketplace. I think ours is open up until right now, it'll probably be extended to early May. There was a lot of pressure for the federal government to do so, and it was thought that they would, but President Trump announced last week that he would not. So for the other 38 states, there will not be a general open enrollment time. They did propose an alternative, which I'll get to in a minute, to deal with those who have COVID hospitalizations. Secondly, Medicaid. All but 14 states have expanded their Medicaid programs to cover all citizens who have an income below, it's about $16,000 for an individual. And so those who are uninsured can go to Medicaid if they're income eligible, and Medicaid is always open. And the portal for it in Washington state is the same as WashingtonHealthPlanFinder.org. And that would not have much in the way of premiums or out-of-pocket costs. Now, in a non-expansion state, which includes like Florida and Texas and several others, somebody who is uninsured but a citizen could buy one of those individual plans on the marketplace, but they wouldn't get a subsidy. So it's effectively unavailable because of cost reasons. Similarly, turning to people who have insurance and what's being done to help them. If you have workplace insurance and you lose your job and you work for a big enough employer for long enough, you can continue your insurance under COBRA. Many of you might have done that. A problem with it is it can be outrageously expensive. And so if a household income is dipped to too low, it can be realistically unavailable. But COBRA is still of the law. Similarly, and under dealing more with the insured population, there have been various efforts at the state and federal level and also with private insurance companies to waive out-of-pocket costs, especially for testing, because it's so important to get a handle on testing where it's available and who has the COVID virus. So testing is free for much of the population, either paid for by Medicaid or insurers waiving it or federal or state new rules. Also, there's been some effort for out-of-pocket costs around treatment of COVID. Now, what about the uninsured? And there remain a lot of uninsured. There were before COVID happened. The administration's plan, after it decided not to open up the marketplaces, announced the plan. And what it is that if somebody's uninsured and they're hospitalized for COVID, the federal government will reimburse the hospital under Medicare rates for that treatment, as long as the hospital agrees not to bill the uninsured person. So this is sometimes known Medicare for all with COVID. That's been derisively labeled. So a couple of issues with this. I'm sure this will be resolved, but right now it does not cover physician bills. So even if a physician treated somebody in the hospital or outpatient care or clinic care, does not cover that. And it does not deal with any other health issue, right, that might come up for somebody, you know, an acute issue or a chronic treatment for their diabetes or arthritis or whatever. That's not covered. It's very COVID specific. There was an estimate that came out yesterday about how much this would cost the federal government under Medicare. The estimate is between $14 billion and $42 billion this year. That would come out of, the administration has said, the $100 billion that's been allocated in one of the relief bills. So turning to your second part of your question, the future, and this relates a little, why didn't the administration open up the marketplaces despite the pressure, including from the own administration, to do it? One reason I think might relate to some things coming up in the fall. And one is there is a Supreme Court argument on a pending lawsuit that argues that the Affordable Care Act, Obamacare, is now unconstitutional and the whole thing must go. So it'd be a little incongruous for the administration to promote the marketplaces or to promote Medicaid when they're also arguing that both those programs should go, expansion program and the marketplaces should go away with the lawsuit. So one question for the future is how will both the pandemic but also the health insurance crisis influence how arguments are presented to the Supreme Court, or whether the Republican governors and the administration decide to drop that lawsuit. Secondly, Medicaid. We're going to see way more people on Medicaid. Certainly in expansion states, low-income workers who've lost their jobs, but also kids. Even in non-expansion states, low-income kids would be covered as a mandatory population if their incomes are low enough. So what does this mean for the cost burden on the states and the federal government, and also the administrative burden on the states? And what will it mean for the program? I just had an article come out about wondering what it means for Medicaid, that so many graduate students and undergrads are now on this historically stigmatized program. What's it going to mean if so many more formerly working Americans who would not have thought of themselves as Medicaid beneficiaries are? So that'll be interesting to see. And then finally, the election, of course, is happening in the fall. And you know, this crisis has really exposed cracks in the healthcare system and the financing system, and made concerns about accessing healthcare and paying for it more of a sort of gut level issue. So healthcare was always going to be an issue for this coming election, but I think it'll be more prominent and more deeply impactful to people. So those are my thoughts.
Thank you so much. So we've covered the public responses and some of the governmental issues that are implicated by the economic impact of COVID-19. We turn now to Steve Calandrillo, the Jeffrey and Susan Brotman Professor of Law, who teaches here at the law school. He teaches law and medicine, law and economics, and contracts to a whole slew of 1Ls who adore him. We turn to him to ask Steve, what are the sorts of responsibilities that businesses might have, and what risks should we expect them to take? Should there be tort liability for experimental drugs that backfire? Should we speed up vaccines before they are fully tested through regulatory channels that the FDA typically uses? What about tort liability for any sorts of injuries that might come from expedited processes? We've seen in the news various reports of things like splitting ventilators or innovative treatments that might be different from usual. We'd love to hear from you about those issues.
Thank you, Dean Said and Schumacher and Barnes for having me. All really good questions. I really enjoyed everything that everyone has said so far. You know, as you said, I'm an economist, so I don't just think about health law, I think about the economics issues. And, you know, obviously when it comes to experimental drugs or rationing care or splitting ventilators, you know, there's cost benefit analysis that needs to occur. Economists are always concerned about the trade-offs. Now, on the one hand, you don't want to go out and just give people false hope saying, hey, there's this new drug out there. It's going to cure all these cases. You see President Trump in his daily conferences, talking up hydroxychloroquine, talking up the Z-Pak, talking up all the other therapies. And, Dr. Fauci and the other physicians are trying to push back a little bit because, again, from the physician epidemiologist perspective, their mantra is first do no harm. So before these drugs are tested, you don't even know if they're effective, and maybe they carry, some risks. You might actually be harming people. And in fact, I saw the American Heart Association put out a letter about the risks of hydroxychloroquine in terms of heart arrhythmia, cardiac arrest. So it's not the case that these drugs have no negative side effects. They potentially do. And so you have to be wary of that. You also want to make sure they're available for people whose indications already are approved, like lupus patients or other immunosuppressed or other folks who you want the drug available for. Now, on the other hand, if you're really in a crisis and you're looking at millions of people who potentially might die, economists also understand you'd have to relax your standards to allow for, treatments or experiments that you would not normally do, right? You don't have the luxury of taking 2 years to test out a drug always. And so you have to compare the cost and the benefits. If it's 2 million people who are going to die without a drug, you're more willing to try it than if it's just 60,000. Now, you'll note the latest IHME models, they've been continuously reduced so that the latest projections are down to 60,000 American deaths. You take very different chances in a world where 60,000 are going to die than in a world where 2 million are going to die. But obviously, anytime you have a crisis like this, you have to think about tort liability and minimizing tort liability in order to incentivize decisions on healthcare providers to do things that they need to do in order to maximize overall social benefit. And we've seen that before. There's lots of attempts right now in the various states to kind of pass tort reform in Maryland, in New York, New Jersey, to try to change the standard of care that providers are looking at or hospitals are looking at if they have to ration care and make these God forbid decisions about who gets a ventilator versus who does not. Attempts to ratchet up normal medical malpractice standard of care from just what an ordinary doctor would do, the normal standard of care, to avoid being liable for negligence, to maybe a gross negligence standard. In Maryland, there's an attempt to eliminate liability for civil and criminal reform for any of the actions taken in good faith to deal with the healthcare crisis that we now face, because you want people to treat. And the last thing they want to be worried about is being sued for having to take a standard of care that they would not normally take. And by the way, there is precedent for this. It's not just states, but Congress can pass legislation that exempts tort liability. For example, when it comes to vaccines, again, vaccines for all kinds of diseases, not just coronavirus, there is some limited risk from vaccines, especially old vaccines that use live viruses. For example, the original polio vaccine, when it first came out, was saving 50,000 people a year, but it was also causing some injuries. And if manufacturers are liable in tort, you might imagine that would disincentivize them from entering into this marketplace. In 1986, Congress passed the National Vaccine Injury Compensation Act, which said we want people to get vaccinated. We want manufacturers to produce. We also recognize that there will be rare cases in which there are vaccine-related injuries. It's not autism like you hear about in the conspiracy news, but there are some injuries that we do want people to be compensated for. But the tort mechanism is not the best mechanism because there's enormous administrative costs in going through tort liability, and it's much more efficient to compensate victims through insurance pools set up under the National Vaccine Injury Compensation Act. And I would imagine we could do something similar here, either on a congressional level or on a state-by-state level. And it's also important to, the last point I want to make about the economic costs is to think about the overall, consequences to our economy. I mean, as Sallie mentioned, you've got 17 million people out of work who can't get health insurance, who can't pay their rent. We have the luxury as lawyers and other businessmen of working from home and keeping our insurance. The impact on vulnerable communities has been just enormous. Gig workers, restaurant workers, Uber drivers, they don't have any of this. And we have to think about the second order consequences of what's happening there. Not just that they're out of a job right now, but rates of depression, alcoholism, anxiety, domestic violence. I saw data going through the roof. I mean, we have a real big crisis on our hands, and we have to think about all of the consequences and how we'll deal with them. I also want to, before I yield my time, put in a plug for some of the presentations on the website. There's some on changing medical malpractice standards of care. Denise Duzinski has a great presentation about crisis standards of care, as well as Aaron Seeberger on what med-mal standards should be, and Doug Ross also on price gouging. And maybe we can get to some of that in the Q&A.
Great, thank you, Steve. So turning now to Anna Mastroianna, who's a professor of law here at the law school and is associate director of the UW's Institute for Public Health Genetics. She teaches health law, bioethics, family law, and her scholarship focuses on the intersection of law, bioethics, and health policy. Playing off of what Professor Calandrillo was talking about in the ethical issues, the UW is one of the premier research universities in the world and is home to the Institute for Health Metrics and Evaluation. And that's the body that a lot of people around the country are relying on, and you see them quoted a lot in the news. The Seattle flu study played a critical role in identifying one of the first documented cases of community transition of COVID-19 in the United States. But the UW confronted legal and ethical barriers in getting that information into the hands of public health authorities. Professor Mastroianna, can you explain to us what happened and why?
Yes, I'd be happy to. Thank you. So this is a story of a study created for one purpose, but found itself useful for another, and along the way ran into areas that required quick legal and ethical analysis. So let's start with the study. So you've all heard of how we test for COVID-19 by collecting biospecimens through those nasal swabs, and it's the same way you test for flu. So these investigators in the Seattle flu study began collecting nasal swabs at the start of the flu season way back in 2018. They got the samples from volunteers who had respiratory symptoms throughout Seattle-King County, so it was diverse geographic socioeconomic sampling. They were in college campuses, homeless shelters, healthcare clinics, childcare facilities, workplaces, and even they had a stand at SeaTac Airport. So, and the health clinics also sent them these what are known as residual samples that were stripped of personal identifiers. So all of these were then tested for flu and other specific respiratory diseases. And they integrated those results with socio-demographic, clinical, geospatial data to track the flu. So it was hoped that this research would result in a model for how to contain public health outbreaks. So with early detection, you could deploy interventions like vaccines and antivirals rapidly to the places that need them the most. So now just some legal background. So importantly, this was not a study designed to diagnose flu in individuals. Research for the most part is not intended to benefit the individual participants, but rather future patients in society. And in fact, these flu researchers were specifically advised even before the outbreak that they were not allowed to share positive flu results with individuals for reasons I'll discuss later. But it's because the testing was done in a research lab and not a clinical lab that was certified to share those results. So going back to the story, after the first COVID case was reported in Kirkland, there was a lag in testing. There was this critical 3 weeks or so when the only test approved for use by local laboratories was not working. And the researchers were sitting on about 2,500 samples that just might reveal the local spread of COVID-19. So they're stuck in this window of time when no one's being tested, and the clinical and public health labs are waiting for the CDC test to get fixed. And it was a long 3 weeks. So they developed what was known as their own quote unquote homebrew test. So now to the law and the ethics, can they test the samples they had already collected? Can they test them for COVID? So first, know that the creation of the test itself by this research lab was fine as long as it wasn't being used to diagnose individuals. And this is because of a federal law known as CLIA. It's the Clinical Laboratory Improvement Amendment. And it's mentioned in Cindy Jacobs' excellent module, so I recommend that you refer to that and access that module. So tests used for medical decision-making have to be conducted by CLIA-certified labs to ensure that these patients' test results are accurate and reliable. And research labs, like those used by the Seattle flu study, they don't need CLIA certification because the purpose of that testing is to gather data for research and not, as I said earlier, to report patient-specific results, and that's by law. So, and secondly, another area of where there were legal issues is that we have research regulations in place to protect human subjects and to protect their rights and interests. And these research regulations, as interpreted by our local research ethics committee, allowed the investigators to add the test to this respiratory virus testing panel without going back to the individuals, with the assurance that future research participants would be notified that they would be tested for COVID. So they test, and they know that their work would be a research contribution, and they also know that CLIA is going to prevent them from sharing any identifiable results for health purposes. But then in late February, they get the first positive that suggests a case of community transmission. What to do? So here's the next ethics and law problem. So existing ethics guidance from major respected non-legal professional groups, so it's not the ABA, these are professional scientists, medical bioethicists, getting together and coming up with their opinions. They supported a liberal but a very narrow interpretation of CLIA. That is, if the test result is clinically actionable, if it's valid and it's urgent, you can do a clinical handoff. You can give that information to an individual with the caveat that they have to consult a medical professional. So you can share a research result with a research participant. But even before the outbreak, the Washington Department of Health had communicated to the researchers that notification to the individuals, even for flu, was prohibited under CLIA, so notification was not an option. So a workaround in this case was a new and untested provision in research regulations that provided an arguable claim by the UW Research Ethics Committee that the activity could be classified as public health surveillance. This is brand new 2018 regulation. Using this interpretation, the researchers were able to contact public health and provide the information about the individual, presumably with an awareness that the individual would be notified through respected public health channels. And you know the rest of the story, the teenager in Snohomish County identified as the first community transmission. So flash forward one long week, the CDC test is finally up and running. Local public health refused to take any more positives from the research samples because they had capacity limitations. They were pretty busy. And they were really concerned about CLIA's interpretation and application, and also issues of consent by the participants. So the Gates Ventures, which is the private arm of Bill Gates, the private investment arm, they provide additional funding, and the flu study has now converted to the Seattle Coronavirus Assessment Network study, so it's called SCAN, to support the public health authority. So a real public health surveillance switchover to comport specifically with that exception in the regulations. So the samples can be tested in a CLIA certified lab as of March 19th. And they are, as I said, working in collaboration with public health authorities. So to sum up, as law students and lawyers well know, the law really can't envision every possible application or scenario, but you have to work with the law as you have it at the time. And ethics and law always don't point to the same answer, but they muddle through to the best possible answer. So I guess I would say confusion and chaos during a crisis is the norm. And we do have these laws in place to respond to public health emergencies that are designed to balance individual rights and societal benefit, and also to protect people from being harmed from scams and inaccurate information. And this situation in particular revealed areas of legal conflict with ethics, and also new areas of legal interpretation that I think are worthy of post hoc evaluation, but working in collaboration with regulators to ensure that the decision making, which I've skimmed over very quickly, but it was really fraught at the time, that it would be really nice to see that there would be attention to this in the event that such an issue arises in the future.
Great, thank you very much, Professor Mastroianna. So other ethical issues centered around, and Professor Calandrillo mentioned this, is, so what do we do? What are the ethical issues when there are scarce resources for masks, ventilators, ICU units? And this is an issue here in the US, but maybe even more pointed globally. So Professor Sanford, if you would give us a few minutes, and I'll ask Professor Taylor to chime in on some of the issues more globally. Sallie?
Yeah, sure. Given the time, I'll just mention a couple of points. One, I think it's so wonderful and so reassuring that based on the most recent IMHE data, and this is out of the University of Washington, it looks like there's not going to be an issue in this area, in this state, about the need to ration ventilators or ICU beds, which was a real concern in this area and has been a concern certainly in other countries and in other places in the US. So it looks like we are not going to have to move to what are called crisis standards of care, where you need to make these decisions about allocating scarce life-saving resources. So that's good, at least good for this region right now. Secondly, I want to point out that this situation with COVID is unprecedented, but it was not unpredicted. There has been concern for a very long time about if there were a respiratory pandemic, that we would not have enough ventilators, we would not have enough personal protective equipment, we would not have enough ICU beds. So concerns about what's known as space, stuff, and staff have long been a concern. I mean, I wrote about this 10 years ago. And about that same time, in this region, there was the development of what came to be known as the Northwest Crisis Planning Network, which did a lot of work, including on how to make these allocation decisions. So, so that's been around, and they've been working on what do you do when you move from what we are in now, which is called contingency standard, where you are doing all you can as a health system and also as a community with social distancing and whatnot, which you're doing all you can to prevent having to move to crisis standards of care. And so some of the decision-making points and ethical aspects of when you do move to crisis standards of care are universal around the world, and some are particular to the US and also being actively debated right now. And before I mention exactly how to plan, I want to encourage what Steve said to turn to Denise Dzinski's presentation, which is on the Department of Bioethics website, which goes into more detail and also speaks directly to healthcare providers about the difficult decisions they might have to make and how to deal with them. But basically, when you move to a crisis standard of care, you shift from looking at the particular patient and what the patient wants and what's medically indicated to considering allocation decisions based on the greatest good for the greatest number of people. And ideally, there would already be in place guidelines, which we have, to help figure that out. And they need to be transparent, they need to be fair, they need to be set out what the criteria are, and they ought to have particular concern for vulnerable populations in our communities. And it's particular to Washington, I think there's a couple of nice features. One is that the decision is not to be made by the treating physician, rather by a triage committee, which would get blinded data about what the clinical indications are for this patient and whatever factors are part of the rubric of decision making. Secondly, that the decision to move to crisis standards of care would not be made on a hospital by hospital basis, but regionally, considering when a region is overtaxed. So I think those are a couple of key points in what Washington's framework would be based on all this decision making and thinking about the ethics of it and some of the actual factors that come into place.
Thank you. And we should probably, sorry to cut you off.
Okay, that's fine.
Give Allyn a quick chance to answer, and then let's try to leave 5 minutes there are a couple of questions that have bubbled up and questions that came in through class reflection. Sorry to cut you off.
Yeah, no, that's fine.
Allyn.
And I just want to say a few words from an international human rights perspective about how this virus is exposing the tremendous social and economic inequalities that exist in this country and around the world, and in fact shining a light certainly from a more broad perspective on the indivisibility between economic, social rights on the one hand and political and civil rights on the other. And obviously we can't do the subject justice here, and I'm creating a small video myself. You know, in the United States, we're seeing daily news stories about the inequitable impact of this virus on population groups. Headlining recently is how hard-hit African-American communities in Chicago's underlying health and economic conditions are making them particularly vulnerable to the disease, or the day laborers who need to go to work to buy food for their families or to pay the rent. And perhaps most recently about the impact that this virus is going to have on rural communities that lack access to care. You know, at the same time, the news is full of stories of angry neighbors about New Yorkers who are fleeing their wealthy homes to their other healthy homes in the Catskills or in the Hamptons. And there are actually similar stories coming out of Europe of wealthy Europeans fleeing to their country homes. So this virus is shedding a light on sort of the deep inequities that exist in the United States and abroad. And globally, these disparities are magnified. Just yesterday, Samantha Powers reported about how economies in low-income countries are being decimated by the global shutdown. in trade and the impact that this is having for communities throughout the world. And I believe we need to keep in the forefront of our consideration that the impact that the virus is having on hundreds of millions of people throughout the world who essentially live hand to mouth. It's important to recognize that public health measures applied equitably to entire populations can have an inequitable impact. The New York Times reported that in India, the government's 21-day shutdown of the population of 1.3 billion people has been described as an order to starve. Yesterday, I had the opportunity to speak with UW graduate students at the law school who reported to me how military and police are being rolled out in places as in some of the states in Brazil, as well as in cities in Kenya and South Africa, to enforce stay-at-home orders as desperate people try to leave their homes to earn daily bread. So I think this virus has truly laid bare the indivisibility between economic and social rights and civil and political rights. And I hope that in a post-COVID era, at the very least, we can have a deeper discussion and thinking about these issues. Thank you.
Thank you so much. So one of the things that we thought we would try to do at the end here was reflect on where we have just come in this conversation and where we're going in the course. We've been focused on the role of the pandemic in the context of public health and global health issues. What other aspects of law do you see as being impacted by COVID-19? One of you joked when we were preparing this panel, well, what doesn't it affect, right? I mean, its impact is so potentially broad, but are there things that you've been thinking about that we haven't touched on yet? And maybe let me start with Steve, whom we haven't heard from in a few minutes, and just see what's on your mind.
Well, already we've raised so many issues, and I hope to crash a lot of your classes as you go through the next 6 or 7 weeks, because so many of the issues are being touched upon, whether it's con law or vulnerable populations. You know, I do think the world's going to look a lot different from this, even after we get past this and we get a vaccine for this. I mean, I really worry. Maybe there'll be some benefits. Maybe people will start to see that there is some social responsibility that we all have. You know, economists are always talking about bringing private incentives in line with social desires, because everybody acts rationally in their own self-interest, or at least we think we do. But that leaves a lot of other people left out. And so, you know, in your future classes, hopefully we'll address some of those issues. And who knows, like, how long it's going to take to get back to what we used to have. I saw Dr. Fauci talking about that yesterday. Chris Murray, who runs IHME, was talking about that. They're thinking, he was thinking about, you know, widespread testing, widespread isolation, maybe even tracing. But we need to get down to a point where we can have 60 deaths per day as an acceptable amount. And I think we need to think about these costs and benefits and these trade-offs in terms of, you know, where we can be and when we can try to reopen up society so that we don't leave hundreds of millions of people with nothing.
Thank you. And other panelists, I know, Pat, you spoke first and we haven't heard from you in a few minutes either. I don't know if you want to jump in or if others have thoughts to share. One of the questions we received over in the side panel from one of ours is whether we ought to think and how we ought to think about the president and a potential conflict of interest if the president is advocating for medicines, if in fact there's a financial stake there, and some of the kinds of conflicts we might think about more broadly as we inhabit this kind of experimental uncertain space. Nobody wants to take the bait on that.
I'd say it's absolutely something to watch out for.
Allyn?
Well, I actually don't want to take the bait on that one, but I wanted to mention another area of the international law that is going to be very relevant, which is international trade law. As it has been in the past, there's an agreement on sanitary and phytosanitary issues that would, you know, they're likely to be raised as, you know, trade embargoes on products from affected countries take place. So that will be an important area of concern.
I think in the aftermath of this, we're going to have to reevaluate how we balance the national and state and local powers. I think this has really pointed up a problem of when the national authorities do not seize the power that they have. And we've already seen, Steve talked about the National Vaccine Act. That's an excellent example of the federal government stepping in to deal with a situation where vaccine access and problems had to be addressed at a national level, and the national government did step in. Here we have a situation where the national government has not stepped in. And while we cannot deny the amazing work that has been done in some of the states and local governments, the fact of the matter is that this is a national and international epidemic, and it merits a much more cohesive approach to the epidemic than our governors and our mayors are going to be able to do. And so I think one of the things that this may help is the idea that our national public health powers need to be addressed and dealt and elevated so that we can address future epidemics like this. And indeed, we need to not cut ourselves off from the international legal order, but if anything, build more cohesive bonds, because none of these pandemics are going to be isolated to our nation. They are going to be worldwide pandemics, and we need the strong linkages to other nations and international organizations in order to address these in a reasonable, cohesive fashion that will allow the most people across the board, whatever class or society, to survive.
Thank you, Pat, and thanks to all of our panelists. This was fabulous. I learned a lot. So a couple things before we close. First, I want to plug what the law librarians, Mary Wisner and her crew, are doing. It's a great repository on information on this. So go back to that regularly, as I do. So next week, we're going to be talking about constitutional law issues, fleshing out some of the things that Professor Kuszler introduced. We're fortunate to have Erwin Chemerinsky, who's the Dean of Berkeley Law School and one of the foremost constitutional law scholars in the country, and our own Lisa Mannheim will be speaking on that. So I look forward to seeing all of you next week at 12:30 or a little before. Thanks again to our panels and to the Dean for hosting us, and to my colleague, Professor Saeed. And for you students in the class, take a 10-minute break and we'll see you back at 1:30. Thank you.